Hello, everyone. It's a true honor for me to introduce Dr. Ken Anger today. Dr. Anger is a professor emeritus here at our institute at OHSU and was formerly the associate director of our applied science group. Additionally, he served as the director of the Oregon Healthy Workforce Center, which is one of the NIOSH-funded total worker health centers in the country. With a background as an experimental psychologist, Dr. Anger started his career and dedicated 20 years to NIOSH, focusing on neurotoxicology research and developing NIOSH's first intervention studies. He retired from NIOSH as a scientist director in the Public Health Service. After his impactful career in NIOSH, we were incredibly fortunate to have Dr. Anger join our institute as a scientist and associate director. During his time here, he played a vital role in developing our applied research group, contributed to hiring all of our current applied faculty, including myself, and initiated the NIOSH-funded Oregon Healthy Workforce Center. He also created and led our institute's outreach group. Even after retiring as a professor emeritus, following 33 years of dedicated service, Dr. Anger continues to make significant contributions. Just as he retired, though he still mentors our safety climate lab, he was invited by NIOSH to conduct this systematic review that is subject of today's seminar, Addressing Healthcare Workers' Mental Health, a systematic review of evidence-based intervention and current resources. And he tells me there's a small surprise at the end. With great honor, and without further ado, let's extend a warm welcome to Dr. Anger.
Well, Emily, thank you for that lovely introduction. I very much appreciate it, and sure enjoy remaining as mentor of your safety climate laboratory.
Thank you.
So I appreciate the introduction, and I am a professor emeritus at the Institute of Occupational Health Sciences, Oregon Institute of Occupational Health Sciences at OHSU. And in this project, I want to acknowledge my two co-authors, Jen Dimoff and Lindsay Alley, who conducted with me this review of the literature. The funding is shown at the bottom, and it really is NIOSH funding, a NIOSH contract to do this work, and it funded myself and Jen and Lindsay to do this. Happily, it was accepted by American Journal of Public Health in November as an article. It should be online, available online around the end of 2023. And I do also want to say that the findings and conclusions in the seminar are from the authors. They're not from the funding organizations or the organizations that we work with, but just from ourselves. Well, what's the scope of this review? It's really to develop an accurate, comprehensive assessment of proven interventions, proven meaning evidence-based or published interventions, best practices, and resources that are currently available for the prevention of adverse mental health outcomes in the healthcare workforce. So that was the frame or the scope of the review. So who's our target audience for this? Really, it's the people who run the healthcare systems. It's the health system safety and health workers or directors and the HR departments and the people who serve those. Often psychologists serve this as well. And so they're really our target audience. Well, what methods do we use to do this search? It's standard methods that you would expect to see. So up at the top, we show this target population which you'll identify here, physicians, nurses, etc., were the terms we looked at. How did we identify mental health when we did the search? Well, the terms are shown in the middle. Depress, for example, for depression and so forth. A lot of terms were used for that. And then third, how did we identify them as interventions, the study's interventions? And so we look for the words intervention, program, training, computer-based online resource, or app. Now, app, we didn't really include any apps. There are virtually no evidence-based apps, and there's another group led by at the University of Denver that was collecting that information, so we didn't include that in our search. Well, where did we start that search at, that we applied those methods to? And really, it was Medline, PubMed, PsycInfo. We looked at the NIOSH Total Worker Health Centers of Excellence websites, and we also looked at Google and DuckDuckGo. Our search timeline, we really performed this review in 3 waves. One was September of 2021, March of 2022, and then during the review process for the journal submission, they identified a new summary source for us that we went to in August of 2023. So we looked at all that peer-reviewed and gray literature up to, in the end, March of 2022, plus Total Worker Health Centers, to identify the articles. So the articles were gathered and screened for relevance by Lindsay Alley, who many of you know, a senior research associate, who really has a lot of advanced expertise in systematic review methodology. And down at the bottom left of the screen, you see a Covidence screen. So we brought it into, imported the articles into Covidence and further screened for title and abstract by 2 of the 3 authors. We were blinded when we did that. And then we did a full text review for those that survived that selection process. And that was done by 2 of the 3 authors for exclusion and inclusion. We also applied the Downs and Black 98 quality rating. There are 25 items we have in the Downs and Black quality review. So right after we read the article, we would go and we did the quality review as we were going through it. And if you know Downs and Black, there are a few more items in that. They were particularly related to clinical interventions, so we dropped a couple of things out to get down to 25. And what sort of ratings did we have? They were in the Downs and Black 98. They were external validity, internal validity or biased, or internal validity or confounding, and power. Well, what level of agreement do we have? We raters, and so our inter-rater reliability and kappa were both calculated for the abstract review, for the full text review, and for the ratings. And we also discussed the ratings and reconciled as a group. In some cases where there were divergence between the ratings, and what we got in terms of our percentages after that was done were about 0.8, which was our goal, was to hit 0.8 or above that. So how many articles were included? Well, we started with, when Lindsay did the initial search, we had 5,158 publications, of which just under 5,000 were peer-reviewed manuscripts. In the end, only the peer-reviewed manuscripts survived the review. And shown down at the bottom is this identified for us, or we identified in this, 118 different interventions. So when were these things published, these 118 interventions? Well, the beginning of time for these interventions was 2003, when the first ones were published, and the most recent ones were in 2022. Now that 2022 bar would have been a lot higher, except we stopped in March of 2022. If you remember, that was the end of our search period. So you can see that during the COVID period of time, when we've had COVID in our life, that's when the largest number of publications, and of course that COVID really stimulated a lot of research projects. Well, where'd they come from? Well, the most were conducted in the United States. Next after that were in Italy and Canada. However, they came from all over the world. This shows you a map of the world and the number of interventions that were conducted in the countries where the numbers are shown. And you can see that the next largest number were conducted in Europe and in the United Kingdom, Great Britain. But there were some from the next largest group really were from Asia, 7 from China. And if you look down, there's one in Malaysia, 4 in Australia. There were several in Africa and a couple in South America. So really every part of the world was represented in that. And you may wonder, well, why'd you include all those interventions from health places where the healthcare systems are really different from the United States and really different from, and where the populations, the culture of the populations is really different than we find in the United States? And the answer is, first of all, we weren't just looking for the United States, we were really doing this for the world. And I also felt that that any place, any intervention that was done any place could be the relevant intervention for someone somewhere in the United States. Could be in a rural area, in a rural healthcare setting, that something that was done, an intervention that was done in a similarly rural setting somewhere around the world would be the one that was useful for them. And I felt we should not make decisions for those healthcare administrators that were our target audiences. So we included all of them. So what about the quality and confidence ratings? Well, let's really just focus on the quality ratings from Downs and Black. So remember, there are 25 possible rating points that we could give, and the highest number we gave for any articles was 22. And between 20 and 22, which we thought were really high quality ratings, there were 20 articles, and that's about 17% of them. There were about 48 articles that received a rating from us of, and that was an average rating, remember, of 2 raters. There were between 15 and 19 rating on the rating scale. And then below that, about 42% or 50 articles received ratings from us of 6 to 14. So they were lower, but they still had value in them. And remember, these are the studies. These that we're rating. We're rating the quality of the studies. Now, the quality of the publication of the interventions themselves is different. They may have been really excellent interventions, but the people doing the study didn't have the time or the money to do a really randomized controlled trial or a really expensive intervention with a large population. So remember to distinguish between the quality of the article and the quality of the intervention. There may be some very high quality interventions shown in those lower tier of articles that only received ratings for the quality of the article of ratings of 6 to 14. So to kind of help with that, we also gave confidence ratings that were just the 3 raters who did this, our confidence after reading an article that the truth was there, that if somebody replicated that study, they would find a similar finding. And so you can see our confidence ratings range from 1 to 4, 4 being the highest. And so there was some that we had very low confidence in, but fairly high confidence, very high confidence in others. So we've got that rating in there as well. But that's a qualitative rating, whereas the Downs and Black rating was a quantitative rating. Okay, what about the design and the number of subjects? Well, the number of designs are shown on the screen. The most prevalent one, fortunately, was the RCT, or the randomized controlled trial. 52 of the studies, or 44% of them, were RCTs. Quasi-experimental studies, still a good design. It's just it doesn't have the benefit of randomization in it. So there were 50 of those and about 42% of them. And the others, there were case studies, descriptive studies, and qualitative studies, which did still have value, we felt. So how many subjects were in these studies? And the number ranged from 11 to 1,575. But most of them were kind of the smaller end of the scale. So there were 46 studies that had between 11 and 50 people. Yes, just 11 people in one study. So about 38% of them. And then another 23% of them had between 51 and 100 subjects and so forth, up to 250. And four of the studies had 1,000 or more people in them. Well, what were the participant occupations? Well, most of them were nurses. Most of them were studies that had multiple job titles. So the percentage on the right don't are not expected to add up to 100. They don't. And we didn't put all the titles in, but the nurses and physicians were the two most frequent, and most of them had, a great many of them had multiple job titles. So what were the study measurement points? That is, after they did an intervention, how long did they measure the potential effects of that intervention? And the majority had both baseline measures and 3 or 6 months follow-up. So not really long follow-ups, because you really hope to see what happens for a really long period of time, because we all know that interventions, fade over time. The effects of them do. So a very small percentage had follow-up surveys of 12 months or more, but a few did. So what were the intervention categories? And I'm listing them over on the left-hand side is how we categorize them after reviewing. Really, Jen Dimoff did this as the type of intervention category that was pursued in an intervention. And a lot of them, as shown in the lower right, a lot of the interventions were coded into multiple categories. So again, percentages don't add up to be 100. But the most frequently intervention was a coping skills development, or were coping skills development interventions to teach coping skills to the individuals who were in the study population who had evidence of mental health problems or volunteered for the intervention because they wanted some help in that area. So we taught taught coping skills development in about 32% of the interventions. Mindfulness is a very popular way of dealing with mental health issues right now. And so that was kind of a category in itself. They were teaching mindfulness to the people in the study. Health literacy and anti-stigma, reflection and relaxation, peer support. You can see the percentages and the numbers of studies down the side. Now, each of these categories, these intervention categories, are really individual type of interventions. You're going in to help the individual. The next one, organizational and system level, is where you're going in to fix the organization, to make it a better organization or a place that's better to work and less likely to produce mental health problems. So relatively few of those. One of the criticisms of the literatures, or one of the wishes for this literature, is that people would do more organizational and system level interventions. Of course, they are generally more expensive. And then there were 4 medical interventions. Well, what about the prevention categories? Well, the typical prevention categories that we see in public health are primary, secondary, or tertiary. Primary are designed to prevent the illness before it happens. Secondary, often considered early interventions, are designed to treat an existing injury or illness, to slow its progression, and to help the individual recover. Tertiary are when people have got the problem, a really serious problem. They've got essentially a long-term health problem, and it's to help people manage that long-term health problem, where recovery is probably a less likely event. So how many fell into these different categories? And of course, a large number fell into combined categories. So primary, there were 20 interventions, or 17%. Tertiary, only 1. Secondary, 40 interventions. And then the combinations of the two, primary, secondary, there were 37% of the studies had that, and secondary, tertiary, 11% of the studies had that. So there was overlap in the prevention categories there, and none of the articles actually identified the prevention categories. That was our assessment of it, and really Jen's assessment of the individual articles. So what are the outcomes targeted? So we targeted 44 interventions. I'm going to show them all. So as I joked in my original seminar, is there going to be a test at the end? But of course there's not. But here are the general categories of outcomes that we targeted in yellow. So general health and well-being, stress and strain, depression and anxiety were their own categories. Under general health and well-being, you see subcategories of the outcomes that we look for measures of. I'll mention the measures in a moment. Burnout and compassion fatigue. You know what emotional exhaustion and compassion fatigue is? Remember when right during COVID, the families were not allowed into hospitals. People were dying in hospitals. And it was the nurses and the physicians who were typically at the bedside as the person passed. And then they'd go to the next bed where they had to do the same thing. It was just a horrible situation for the person, of course, dying, for the families that were kept away, and for the people that were doing it. So that was emotional exhaustion and compassion fatigue, if that's not a familiar outcome to you now. Emotions and attitudes, self-efficacy and self-esteem, resilience and coping, mindfulness, civility and relationships, and then finally organization related, which weren't outcomes, mental health outcomes, but other outcomes that are related to how people were doing within the organization or how well they liked the intervention. And so these are our 44 different outcomes that we looked at. And we didn't decide these at the beginning of the project. They came to us from the interventions. If we found them in the interventions, we put them into the list and recorded them. Now, what are the outcomes that were targeted frequently, just to pull back from from the big picture there? And the outcomes most frequently targeted were the outcomes most frequently reported during COVID, and they're listed on the screen: stress, anxiety, emotional exhaustion, and compassion fatigue, depression, and burnout. And the number of studies that addressed each of those incomes, and most studies addressed more than one outcome. I'd say the average was probably around 3 to 5, though some did even more than that. So you can see what are the high frequency outcomes. And I should also say that these outcomes were measured by surveys, standardized surveys, generally had information about the validation of the survey that were also included in it. Workplace measures, there were a lot of measures of intervention experience. There were 38 studies that did that. Very few of them showed improvements. But of course, intervention experience was mostly being measured to find out if people liked the intervention, to get qualitative input back on the intervention. So we didn't expect to see a lot of improvements. And why do you measure intervention experience at baseline? You really can't. So anyway, it's a measure with not a lot of significant improvements. But if you look at this outcomes of stress, anxiety, and so forth, the number of studies that had significant improvements for stress, it was 29 of the studies, of the 48 studies where they had actually measured that. And for anxiety, there were 20 studies that had significant improvements of the 32 studies that actually measured anxiety, and so forth. Emotional exhaustion, compassion, fatigue, 30, with 16 that had significant improvements. Depression, 31, 15 improvements. Burnout, 40 studies, 15 improvements. So what you can see from this, or what the takeaway is from this, is a lot of studies found improvements in as a result of the interventions. So that's on the good news side. So what do we want to know about these 118 interventions? Now we kind of have a picture of what's in there. Well, the first question that I think we want to ask is, are they effective? Do they help people? Second, do some improve the important outcomes in particular? Do some improve multiple important outcomes? Were these from high quality D&B rating studies or not? Keeping in mind that the interventions themselves may have been high quality, even if the study was a low quality study. How long do they cost? What will they cost? Healthcare systems need to know that. It's just to be responsible with their funding, they have to figure out what an intervention is going to cost their system. So we added that information in where we could find that. Are there quick fixes that won't cost as much? Another key question that most healthcare systems would ask. Do any of them fix the organization, primary prevention? Which types of interventions worked reliably? In those categories of interventions, which ones worked reliably? Are these interventions available? Okay, it's fine, did an intervention. Can I get it? Is there a toolkit to pull it off the shelf and I can apply it? Or is there a way I can go in and find it available online, information available online about it? And then finally, can I ask my own question without delving into the giant tables? And my main table in this, our main table in this publication is a supplementary table, and it's 21 pages long. So, you know, not a great, not an afternoon's easy reading. Okay, let's ask these questions or answer these questions. Are they effective? Do they help people? Well, first of all, are the measures good? Well, they are almost all, virtually all of them were validated and standardized. Many of the studies reported Cronbach's alpha, either for the original validation of the measure or for the study that they were conducting, or both. So that was often in there. And so the answer is the measures were good. I've delved into mental health a little bit. Jen Dimoff is our mental health expert in the group, and so when I did my Gulf War studies, I saw a lot of these measures, and so I really recognized almost all the measures that came up, and so yes, they are good measures, and they're survey measures given in most cases, almost every case, before the intervention started, and then after the intervention completed, and at some point later down the line to see if there was improvement and if that improvement had lasted for a period of time. Statistical significance. Studies needed to have statistical significance for us to credit the improvement, credit the change as an improvement. In some cases, they got worse, so those didn't count as an improvement, right? So we could have statistical significance, but in the wrong direction when they, measured sort of two-sided significance, but we only counted significance that moved in the right direction for statistical significance. And what about effect size? Statistical significance is great, but we all know that we can get pretty small changes in a variable, but it can still be significant. And the real way of testing, was there really impact, is to use measures of effect size. And a number of the studies did provide effect size measures where they didn't, if they had enough data for it to be calculated, we calculated it for them, and we identify in the tables where we calculated it versus the authors. And the effect size, I'm just going to put it up on the screen briefly, only the statisticians would be interested. But these are the small, medium, and large effect sizes, or the criteria for small, medium, and large effect sizes. Moving on. So again, are they effective? Do they help people? Well, with that background, the mental health outcomes that are what I'm going to call the top 5. The number that had improvements in them, that is a statistical significance of 0.05 or better or lower. There were 29 studies of stress that showed improvements in the measures. Anxiety, 19, emotional exhaustion, compassion, fatigue, 16, depression, 15, and burnout, 14. Well, how many of those had effect sizes either reported or that we were able to calculate? Well, only about half of them. Why people don't put in effect sizes or why journals don't require that, I'm really not sure, but at any rate. So how many of those were large, medium, or small effect sizes? Well, for stress, there were 5 large effect sizes, 6 medium and 3 small. And as Leslie Hammer made a point in the earlier presentation of the seminar, there were, it's really hard to get, even small effect sizes are important and valuable and important. They really show that there is an impact. So for anxiety, there were 5 large effect sizes or 5 studies with large effect sizes in that measure, 2 medium and 4 small. For EECF, I'll abbreviate it, 3, 3, and 5 for large, medium, and small. For depression, there were 4 large effect sizes, and for burnout, there were 2 large effect sizes. So for each of these measures, there are interventions where there are statistically significant improvements in the measures. There were effect sizes reported. There were large effect sizes found in them. So the answer to this question, are they effective? Do they help people for these measures and for most of the measures in the search, resulting in the search? The answer is yes to this. There were improvements. What we really don't know is where they started, where that baseline measure was. When you get to the baseline measure, were they awful? I mean, were they really seriously mentally have a really serious mental health problems that was affecting their work and home life, or were they slight? And then that large improvement, or small, medium, or small, how much did it move them back to what we might call normal? So I'm not using like clinically definable terms really, but that's what's missing that we really can't answer. But they improve them, there are effect sizes, and there were large effect sizes. Okay, what about those highest quality studies, the ones that were rated 20 or 22? Did they have medium or large effect sizes of those top 5 healthcare problems? And the answer is yes. For gratitude journal, there's a program called, an intervention called, excuse me, gratitude journaling. So there were large effect size improvements in stress, medium effect size improvements in depression. And if you look down at these 6 different interventions, stress, depression, each of the 5 big measures shows up as there was an intervention in a highly rated study. Again, remember the intervention might be very high quality, but still be in a low quality study. But these are the high quality studies. There are effects. Now your eyes might move down to point number 4, which is cannabis oil therapy. And as I want to point out that we're not making recommendations, and healthcare systems might be very reluctant to encourage or set up a intervention where they're doling out a cannabis oil to people. But and this study was done in Brazil, but they did it. They had medium effects on anxiety and depression of their measurements. So again, we're not recommending anything, and we recognize that some of them people might be reluctant to use. So how long do they take? What do they cost? I mean, this is such an important question for healthcare systems that want to adopt such an intervention. Well, the range was 0, which was when they were conducted outside of work time, for example, cannabis oil therapy, to up to 50 hours, where it took the intervention itself for individual participants took them 50 hours to complete all the steps in the intervention or listen to all the lectures or individual consulting or healthcare, whatever the healthcare intervention was, it took them 50 hours to complete the intervention process. But there were 55 interventions, about almost half of them that required 10 or fewer hours, which I think is a very hopeful, is very hopeful for healthcare systems, because 50 hours is a lot if you consider the number of people that need interventions in a healthcare system, cost-wise. So did any take on all of the top 5 important outcomes that we've identified? And there were 2. The intervention shown on the left is mindfulness-based cognitive therapy for life. And then the next one down is mindfulness-based resilience training. Those 2 took on all of the top 5, and they found they'd measured 8 outcomes. And what's shown on the slide in the middle column, for example, is the first one are the outcomes improved and the effect size. So the stress, there was a medium effect size improvement, depression medium, anxiety small. Where there's a dot or a period is they measured it, but they didn't find a significant effect. Excuse me. They did find other effects as well: well-being, mindfulness, self-compassion. Looking at the other one, kind of a similar story: emotional exhaustion, compassion fatigue, a large effect size improvement, stress medium, but no improvements in burnout, depression, or anxiety, but 2 other outcomes that had a large and a median effect size. So there are some interventions that took on the whole mass of them, but they didn't fix the whole mass of them, of the 5, I should say. So again, the dot is measured, but the change was not statistically significant at the 0.05 level or better. So do some improve 0.05 or better multiple important outcomes? And the answer is yes. And there are the ones that are listed up there are the number of are the different interventions that improve multiple important outcomes. The number of outcomes improved by the first one was 7. That was the crew intervention. 5 for the next one, 4, 4, 3, 3, 3. So yes, they took on the multiple important outcomes. So which outcomes did they improve? Okay, they took them out, but which ones did they improve statistically significantly? They're listed here. So they took on a lot, they improved a lot. And I'm not going to go through and read each of the ones. The main point is they took on a lot and they improved a lot. Well, the country they came from is important, as you're reviewing these. So what countries did these come from? Well, the US, Canada, Turkey, and Italy are where these ones came from. And most of them were pretty recent studies. What was our rating, Downs and Black ratings of them? Well, from 17, which was really still a pretty good rating. Remember, 20 to 22 was what we thought were the very best studies. And so 18 and down to 16, 17, and 15 ratings, which were clearly lower ratings, but still creditable studies. One for you to judge yourself. Now, back to that other question, how long did they take? So if they improved multiple important incomes, which you might say, hey, that might be a good one for our healthcare system, but what's it going to cost us? Well, the answer is not a lot of time. Where we could calculate, and I was the one who really went through the studies and tried to calculate the number of hours that people had to spend to complete the intervention. So, and where there's a dot, it was not calculatable. I mean, one of the most interesting one is certainly next to the bottom, which is the expressive writing one, where expressive writing was they asked people to write down the things that they'd improved, the good things that they'd done during that day, to bring them to thinking of in a really positive vein, compared to ones that were just to write things in a neutral way. So they had outcomes were changed, positively changed of depression, PTSD, and psychosocial functioning. Similarly, that took very little time was acupressure and emotional freedom techniques, which was it's kind of a medical manipulation and some teaching. And so they improved, and it was 0.33 was the amount of time it took. It took about a half an hour to complete the training. That was done in Turkey in 2021. So worth considering is that there are some interventions that don't take a lot of time, but really improved a number of important outcomes. Of course, the real question for any healthcare system is, what are the outcomes we need to improve in our system? Right. Are there any quick fixes, really quick fixes? Well, the two quickest fixes, because they took virtually no time, were the daily indoor or outdoor work break intervention. But unfortunately, as you see at the right, on the side at the right, they didn't really improve anything. The cannabis oil therapy did improve things, and that was the other one that had a really small amount of time. Others that also took a small amount of time, a little bit more, but still were 45, about 45 minutes or less than an hour are shown in this slide. And here, while they were quick fixes, there really isn't too much of an impact. The cannabis oil therapy, as we've talked about before, did show improvements, and the acupressure and emotional freedom techniques one did, but the only other one that really, the only really one that had much of an impact was stress management for nurses, and that affected the stress at a medium level. Okay, continuing, are there quick fixes, those that took about an hour to do it? Well, here we get expressive writing intervention, which had large effect sizes, but that's the only one that took only an hour. So I think the thing that we can see from these studies is that when you don't invest a lot of time in the intervention, they don't make a lot of improvements, but there are some that have, and so they may be really worth considering if you don't have much money. So what about fixing the organization? What about primary interventions? Well, as you saw in an earlier slide, there weren't a lot of them. And there were two of them that had real impacts. The first one is STAR, Sport Transform Achieve Results. Study conducted by Leslie Hammer, and Ryan Olson and I were also involved in that, but a lot of people from other institutions were involved in this sort of multi-group study. But they found small effect sizes on distress, and there were a whole bunch of moderated effect sizes in there. It was the only study that actually did moderation analyses of the 118 that we looked at and included in it. So moderated was like a worker who had parents to care for and children to care for, but were still working a full-time job. They had an impact of this intervention, but the ones who didn't have that didn't have it. So that's what an example of a moderated effect size would be. And then looking down at the bottom, towards the bottom, Health Circles organizational intervention done in Germany in 2019, not highly rated, took 15 hours, and the only thing they improved was essentially job control or decision latitude. But they didn't improve the mental health outcomes. And the others didn't have any effect, really. They measured it, but they didn't have any effect. So do any of these fix the organization? The answer is kind of not much, or very few, and there wasn't much of an impact. clearly an area later of need for improvement or growth or increased intervention. Well, increased research on interventions. Well, what about the intervention types? Among the most highly rated studies, coping skills development and mindfulness interventions had the most studies associated with improvements. These worked. 26 studies, 22% for each of them. There were 26 studies that were associated with improvements. So these worked. These worked to fix problems. Again, they're fixing the individual, if I can use such a non-clinical term, but to get the point across, they were effective. So coping skills development interventions produced the largest number of large effect sizes. There were 6 studies that had large effect sizes among the key 5 outcome measures, and mindfulness was associated with 4. So these types of interventions were associated with large effect sizes improvements. And the most impactful was coping skills development. Of the coping skills development interventions were one called SMART that had 7 outcome measures improved, 7 with effect sizes, 5 were large. It had a D&B rating of 20, though it was a quasi-experimental, not a randomized controlled design. And then the second one that had 3 outcomes was acupressure and EFT. The most impactful mindfulness interventions were the 2 listed down there. They were mindfulness and cognitive therapy in each case. So there were 6 outcomes. The first one, it was 6 with effect sizes and 1 large, and the second one, 4 outcomes, 4 with effect size, all 4 with effect sizes, and 2 were large. And both of those had pretty high ratings, D&B ratings, and they were both randomized controlled trials. So, are there highly rated and successful 1 effect size in the top 5 interventions that are available, that you can go take what's published in the intervention, any auxiliary materials they might have available, and get them? And the answer is almost 1/3 of the 118 or 37 of them are described in sufficient detail to enable implementation of the intervention, or they're available from the intervention authors, at least in my view and my assessment of it. So, and these are the ones, examples of the ones that are available, certainly not all of them, but these are the highly rated on D&B, on the D&B scale. They were successful in there was at least 1 effect size improvement in the top 5 problems, and that they're available. So that's, I think, a hopeful sign for us. So what are the key takeaways? Well, 118 studies met criteria. That's good. There are a lot of those studies now. The majority of the interventions were published during COVID. Almost half of them were. 19 studies, 16% scored high quality ratings. So of those 118, there's a group of them that had quite high quality ratings of the studies. Again, the interventions may be terrible, but the study was good. But if they, so then you look to see, do they have an impact, obviously. But the interventions could be very good and the studies could be terrible. So really all of them are worth considering, I think. Most frequently studied outcomes are the ones we've talked about so many times: anxiety, stress, depression, burnout, and EE, compassion fatigue, but also general health. Most studies used well-validated measures. You can trust the measures that they used. They've been used in many other studies. The majority used mainstream methods. The interventions were not weird. Nobody ever heard of those. Whoever thought of bringing those ideas together? There weren't things like that. They were mainstream methods: mindfulness, acceptance, and commitment therapy, cognitive behavioral therapy, which is CBT, with a few one-offs. You know, my personal favorite being the puppy program. They set a room aside, they brought in puppies, it helped. So anyway, most were standard methods. Most focused on individuals, fixing people, not systems. This is a real gap. This is something that is really needed to work on, fixing systems, not just fixing people when they've got the problem developed. Most measured changes at 3 to 6 months post-intervention, also a problem. That isn't very long to know. We know a lot of interventions in the wellness area in particular will improve, but then people kind of go back after a while because the impact of the intervention goes away. So it'd really be nice to know longer periods of time. And I think we'd be wise to look beyond healthcare for effective mental health interventions, though the range of methods used in these 118 is good. I mean, when we looked at other industries, and Jen Dimoff did this, she didn't find a lot of new interventions that hadn't been used in healthcare. So the range of these is good, but it's still, we'd be wise to look at interventions in other industries because some of them were really impactful. And of course, most industries kind of think that they're unique. Of course, most of them are. And they only want to see something that's worked in similar industry, similar companies or organizations. So that's understandable, but still we should be open to those other interventions in other settings. And well, you know my email address. So I'm going to stop sharing now because then there's that question of, can I ask my own questions? Do you want to read a 21-page table organized from the best to the worst D&B study quality ratings? Probably not. I can't see the audience, but I don't see a lot of hands raised to something they'd want. And here's what it looks like. Oh my gosh. So what did we do? We developed an intervention selection website from which you can go in and select the kinds of categories of things you're interested in. And I'd like to show you that now. Okay, here we have, I'm just going to kind of get rid of the intervention. So I think I'm just sharing Firefox, right? So
Yes.
here's what the intervention website looks like. And so on the right-hand side is are all the interventions, all 118 interventions are presented. And it starts, if I click on, you notice there's three little dots, you click on that, shows all the information provided. And so it begins with a journal abstract, then it comes down and mentions the outcome probability values. The same code is in the slides that you saw. So stress, for example, had significant improvements at 0.001 or better. Then what was the intervention categories next? This one was reflection and relaxation, the time per employee in hours. This one didn't have time specified. The D being quality rating and our reviewer confidence rating are next. What country did it come from? Oops. What country did it come from? This one being China. What was the study design? What was the prevention category? What was the effect? Was there a large effect size? The answer is identified there. What's the reference? And then it is a clickable link to the article itself. So each study has that information put into it. And then if you want a user guide, this kind of tells you like about the user guide. If you want to see about oops, you can see the pictures of the three lovely authors, or anyway, who did the process and so forth. And then you go back to the intervention and selection. If you look on the left-hand column, the items you can select are the first author. You can select the outcomes. Now let me just click on this one. So all the outcomes show up. So you can look and say, oh yeah, I'm interested in distress. I'm going to look at those 14 interventions. If you click them, then on the right-hand side, only those interventions show, those 14 interventions show. I'm going to now clear it back and get out of that. And then say if you, now I just don't have much money. I want to just look at those interventions that have, say, 15 hours or less. Well, those are the ones that show up on the right-hand side. I'm going to clear that again. Then if you say, well, I want to go to the intervention categories, I'm just interested in medical interventions, or I'm just interested in reflection and relaxation. Well, there are 24 of those. You can click on that and you'll only see those interventions. So I'm going to clear them all again. And then you can go down to the quality rating, the reviewer confidence, the country, so you can see all the countries identified. If you're just interested, say, I'm from Portugal, I want to see the one from Portugal. And that's the one you'll see as the only one you'll see. Going to clear them again. So study design type, are the materials available? Yes. The prevention category, primary, secondary, tertiary, the effect size, large, medium, or small. So I'll say, I want to see just the large effect sizes. And you can click on that, but you can also go down and find the measures that have large effect sizes in them as well. So this is our selection website so that a healthcare system person can go in and look at the criteria or the things they particularly are interested in and just focus and just read about those interventions. And then once they do that, they can then look at what this abstract says and they can just click on it and say, I'm going to go to the study and find the study. So that's our intervention selection website. This is my surprise at the end.
It's very cool.
I thank you. We've worked a lot on this, and I pitched it to NIOSH because they asked if I could come up with a repository concept. And I said, well, repository, you just put articles in a place where people can go find it. That isn't too helpful. How about a selection website? I don't think we're interested in that. So they weren't interested in it. And so I decided, just out of the money they were paying me to do this, which was really generous, I just paid for it. And this website, guess how much it cost?
Should be quite expensive, right? Yeah.
No, it was in the end, it was about $4,000. I had some extra things put into it, but it was about $4,000 because the web developer I found had already done this for a similar thing for something else. I forgot what it was, but he had experience in this. So he already had a development environment identified that had a lot of this. And there was an additional cost to get these question marks over here. If you go to the question mark under the each of them, it defines what the filter is about. So intervention category, it tells you what it is and it gives you the definition of each. Hours per employee, length of time for putting these question marks and having that come up cost me like $800. At any rate, it wasn't terribly expensive. It's I think a useful
Yes.
mechanism that people can use, because who's going to read a 21-page, table? They're not. It's just not very useful, it seems to me. Anyway, or not as useful.
Great.
So that's my surprise. So thank you very much for attending the seminar. And if you have any questions, I'd be happy to answer them.
Right. Yeah. Thank you so much, Ken. We really appreciate it. Yay.
Oh, thank you very much.
Is this a standalone website at this point? I'm a little unclear.
Yes.
It's standalone. Okay.
Yeah.
And can you share the URL?
Yeah, it's shown up at the top.
I can't see it. It's too small.
I'll send it to you.
Okay.
It's healthcare mental health interventions.org.
Okay.
Healthcarementalinterventions.org.
Great.
And this was the one that I came to you earlier, Aaron, and to Leslie to ask to put on the Oregon Healthy Workforce Center.
Yeah,
web.
well, I mean, so I'm thinking just about that because we're gonna have the final website beginning probably at the end of January. So it would be great to think about how to integrate this.
So I will send you that link by email.
Okay,
just
that's
to make
great.
sure.
That's great.
Very helpful.
Yeah. All righty. Well, it's good to see everybody. Thank you very much for taking the time, and wish y'all a Merry Christmas, Happy New Year, and any other holiday that you may celebrate at this time during the holiday period.
Likewise. See everyone in the new
Likewise.
year.
Yep.
Happy New Year.
Everyone.
Bye.
Thank you.
Bye.
Bye
Thank you,
bye.
Ken. Bye.
Everyone.